The program originally graduated a pilot class of 4 students, and we now have 20 students per year out of a total of 50 students here on the Rockford campus. So that gives us a third of the class, or a little more than a third of the class, that's training in rural medicine. The idea is that we select students from a rural background who grew up here in the state, who have an affinity for primary care at med school matriculation. We reinforce that affinity with positive experiences in rural communities. We do some additional learning in agricultural topics and rural community topics, including leadership. We look at agri-medicine, we look at pesticides, chemicals, farming, the risks that present themselves to individuals living in rural communities.
Right now we're at my parents' farm in rural Lanark, Illinois. This is the farm I grew up on. My parents still live here, and they have about 100 ewes that they raise on this farm and 60 cows. I felt like RMED was almost custom made for me. I mean, it's a group of rural people from Illinois, people who grew up on a farm like me or in a rural setting, who basically wanted to practice primary care and back in their rural areas. That's exactly what my thoughts were with my future, and just the fact that you could go to Rockford for medical school, which was fairly close by to family for me, and get to spend 16 weeks with a rural family physician, getting hands-on experience while you're still in medical school, just sounded like a great opportunity.
I applied to the university for med school, and I got a email from Mark Meyer, the recruiter for RMED, and he found out that I was from some place out in the middle of nowhere in Illinois, which is how they usually find the med students for the RMED program, and he asked if this program was something I'd be interested in. It was exactly what I wanted to do. I wanted then, as I do now, to be the doctor in a community and kind of treat everything about my patients.
My main focus is recruitment of rural students who wish to return home someday to practice rural medicine. We have found, and other studies have shown too, that students that have a rural background tend to gravitate back to those rural communities after they're done with medical school and residency training to go into practice. Because if you come from a rural area, you're used to that environment, that's where you're comfortable, and our rural students tend to go back to those areas because that's where they grew up. And so they tend to gravitate back to rural communities for that reason.
I grew up in a rural area my entire life, and I want to stay in a rural area. My husband and I are expecting in January, and for us to raise our child in a rural area is incredibly important too. We love the sense of community that's available in rural areas, and just the ability to trust others and to really know everybody and to have everybody know you. So for me, to be able to provide those people with health care is just a great opportunity. I want to bring something back to my rural community that is meaningful, and because of my passion for healthcare, my passion for rural areas, there's just no better fit than practicing primary care in a rural area.
No Harm on the Farm tour is an experiential, outside of the classroom thing that we do every year, where we take our students from campus, we actually go out to a farm, and we allow our students, whether they be medical students, pharmacy students, students that are studying medical biotechnology, interested in public health, where they get to spend the afternoon with an actual farmer. They tour with the farmer. The farmer actually leads the discussion and explains to the students the things that he does on a daily basis, that his employees do on a daily basis. He explains the health and the safety risks that he as a farmer deals with every day. And the second part of the day, we actually do simulated farm accidents so that our students get an understanding of how quickly, sometimes how devastating a farm accident can be. As future physicians, nurses, pharmacists, they're going to deal with these type of injuries and health-related conditions in their practices someday. So this is a way for us to get them out of the classroom, out to a farm, to experience what farm life is like here in the state of Illinois.
The pipeline consists of various programs that help students get interested in the health profession. So those students are elementary students, high school students, and college students who have not yet chosen what they would like to do for a career. For the elementary school students, we have something called a 4-H Health Jam, which we do each year. It involves 4th and 5th graders, where they participate for 2 days down at KSB Hospital in Dixon, Illinois, as well as a camp in the area. They interact with our health profession students, meaning our medical students, nursing students, pharmacy students, and dental students who do hands-on labs with those young students. Starting at the high school level, we have a rural health career camp that we do each summer where we partner with Northern Illinois University in DeKalb. That is a 2.5-day camp where students from rural Illinois, rural Northwest Illinois, come for 2.5 days of learning about the different health professions. So one day consists of rotating through various hands-on labs, which includes physical therapy, nursing, public health, pharmacy, clinical lab sciences, and nutrition. And then they have an opportunity to learn about what would you do if you chose to pursue this profession. There's also an accident simulation where they find out how different health professionals would treat somebody or assess somebody who's coming into the emergency room following an accident. And then as well, they interact with our counselors at the camp who are health professional students either at the college or graduate level programs. Following that, we have our rural interdisciplinary health profession preceptorship, which occurs for 6 weeks during the summer.
I think the biggest part of the program, which I'm really looking forward to, is the preceptorship program. So it's 16 weeks where we spend the whole time with a physician in a rural area in Illinois, and it's like we're the second doctor for the area. So we see patients, we see probably more patients during that 16 weeks than we do the rest of the time in our 4th year of medical school. And you kind of get a real sense of what it is to be the physician for the community. And during that time, you also get to do a community-based research project to kind of get some experience in that in case that's something you want to do later on to help your community.
So you have was there a family doctor that you went to that inspired you, or why did you decide to do this?
Yeah, Dr. Messmore. He was, whenever he was my doctor, he was about 1,000 years old. And he practiced in Arthur for, 40 or 50 years, and he saw everything. He would treat everyone. He would do everything. He did surgeries in the office. He did his own deliveries. He was just the guy for our community.
In some communities, you have physicians who are beyond the age of retirement and are just hanging on because there's nobody to take over their practice, and they don't want to leave their patients, who are also their neighbors, without health care. And I guess in our country where we believe in equality, I feel very strongly that rural should have a voice as well and have the same access to services that somebody in urban or suburban would have.
Well, what I've learned is taking over the rural pharmacy program is much of Illinois is made of rural communities, and what we have found that in rural communities it's a lack of resources. So not only physicians and other kinds of health care providers, but pharmacists as well are needed in these small communities. There are some towns that don't even have a pharmacy. So we have found through some of our contacts that sometimes people have to drive 20, 30, 40 miles to get to a pharmacy. So what we're hoping to accomplish is sort of repopulate these smaller communities with healthcare providers, pharmacy being one of them.
Primary health care in rural areas comes down to access. So in rural areas across the nation and in Illinois, access is a problem. There's not enough health physicians for the patients in those areas. So the rural physician has to have a little bit more responsibility. They can't just punt the medical issues to specialists. They have to kind of treat everything. And if they have that vested interest in their patients in the community, then they not only treat the medical conditions of the community, but also have a interest in the well-being of the community.
One of the things that I think is unique about this program is it is interdisciplinary. So we have medical students and pharmacy students that are training together throughout their 4 years of professional education. So we know from a fair amount of data that's out there that patients get better when healthcare providers work in teams. It's not just one person calling all the shots and then patients get better. So instilling that in our students now knowing that when they go out to their rural communities, the majority, I would say the big portion of medical care that they get is from a primary care provider, from a family medicine doc. But we also know that there are a shortage of family medicine docs too. So it gives us an opportunity to potentially expand our role within the scope of our practice, maybe perform some more primary care type activities. One of the things that we do for our students here is they learn how to do manual blood pressures. We teach them how to do blood glucose monitoring. So some things like that, within the scope of their license, obviously, is something that we hope that they can do. But in addition to obviously physicians assistants and nurse practitioners, we're hoping that potentially elevating the level of practice of pharmacists in these areas could also help with that primary care shortage.
One of the projects we're currently developing is looking at Native American health. So for our First Americans who are now living many times in residential communities in isolated geographic regions rather than distributed across the plains, we look at how could we train students who are Native American by background to come to the university, get an appropriate rural education with the additional cultural elements of Native American culture and Native American belief systems about health, so they could go back and provide culturally appropriate care.
And the primary care physician is the quarterback of the team. They may refer out to specialty care for tertiary care. However, every patient needs someone that is guiding all of the various specialists and coordinating all of this care. I think in a rural setting that's even more important. When we talk about areas that have a strong agricultural base, for example, people don't want to leave the farm and come in to receive any kind of health care. So they need someone to provide the coordination for all of that care. Small towns have a lot of respect for their local hospitals. I think the hospitals are an important economic engine, and the primary care physicians are a big part of that. We find a number of advantages in our partnership with the University of Illinois at Rockford. The first part is our physicians love to teach, and I think our nurses and our ancillary people, the pharmacists, physical therapists, they very much share that love for teaching. And if you're teaching, it makes you understand what you're doing that much better, and that's certainly an advantage when we're recruiting physicians, when they know that we have that association with the residency program. It's also a wonderful recruiting tool for us. We've now hired 5 physicians that came through our residency program, and that's access to these professionals that a lot of, especially rural hospitals, don't have. To have those people down here, to see the rural opportunity that they have in a hospital our size, and then to find that they have that passion of staying in a smaller community is just such an advantage for us. The administrative team at RMED and at the University of Illinois has been wonderful in walking us through the development of our residency program that will be 10 years old next year. And so we're beginning to see those classes cycle through, and that's just it's a wonderful opportunity for our hospital.
RMED just granted me so many opportunities, and really I am where I am today because of RMED.
Having rural primary care doctors is important to me. I live in a town of 1,000 people. I understand firsthand how important a rural doctor is to a rural community. When I was growing up, our doctor, everyone knew who our doctor was. He was our doctor that delivered us. He was our doctor until the day he died. And that doctor, it was Dr. Palumbo, in fact, was his name, is ingrained in the history of our community forever because of the work that he did there. And I know how important a rural doctor is to the fabric of the community, from an economic standpoint, to obviously a healthcare standpoint, and they're vital, and we need them.